Titles, that's as good as it gets for now because I'm confused if I was going to get more precise. But I want to talk a bit about open innovation, the concept. There's a lot of confusion about open innovation, or you may have heard about it as user innovation. I think Rainer presented kind of a lot of stuff that would fall under the rubric of user innovation. Talk a bit about the organizational side. In management, we focus a lot on organizations and kind of how to run them and how to make them more performing. So we'll talk about that a bit. And then we're going to talk at we'll look at a number of medical innovations, which many of them are probably known to you. So open innovation is not a new phenomena. You hear about it in the press over the last 5 to 10 years. It's kind of a recent rediscovery. Like many things in the world, we rediscover them with every few years. It takes maybe half a generation to forget about something, then the next generation rediscovers it and puts on a new label on it. But the Oxford English Dictionary has been using the concept of open innovation to find out what are the new words in the English language. They ask you, the public, to generate the list, and so it's a combination of things. The Mormon Church uses it, and so on. So in the movie industries, they incorporate a lot of new ideas from outside groups, outside players, and but in most organizations, typically, and I would put hospitals in that category, we tend to be more, the boundaries are important. You're affiliated with the hospital or you're not. You have rights in the hospital or not. So these things will matter. So to simplify a representation of this, if you think of R&D or the development of a new cure or whatever it may be, or a new device as a funnel where you start out with a lot of ideas, and then through the R&D process, the funnel narrows. Think of pharma, drug discovery, think of things like that. You have a lot of solutions. You start with a lot of ideas, they become more refined, some are discarded, eventually you come with one or two that may make it to the market. The alternative in the open innovation paradigm is to say, not invented here, which is an old negative syndrome in management. It reflects a tunnel vision, or it's not our way, or we don't do this way here, right? Versions of these statements reflect a mindset that is organizationally defined and narrow, so you lose out on a lot of what's happening outside the boundaries of the firm. So the challenge is to basically make the boundaries of the firm a bit more porous, a bit more crossable, and you can maybe build very interesting collaborations or gain knowledge that you wouldn't have otherwise. So in a nutshell, that's open innovation. So I have a definition here. It's a new form of organizing where basically you pay less attention to the boundaries of the firm, and it's enabled by the technological revolution, which has reduced the cost of collaboration and made it easier to share, with others outside your organization, as you did before. So for many academics here, the cost of before we had departments locally, because, for example, often it's expected you would collaborate with the group locally. But nowadays, for example, I don't see the need to collaborate with people in my, that are down the hallway from me. Maybe the more interesting people is, like Axel here is in Germany, no big deal. We have Skype, we have Google Docs, we may find ways to work together, and those barriers are lower. For the organization that's built up on the culture of we're going to build groups and so on, that's a challenge, because that's not the reality of how I collaborate or the modern researcher collaborates. So there's often a lag between how the organization sees its role and what people are actually doing and at the margin, or the innovators are doing. So to achieve this, you basically, in the health system, it's really crucial to think of, first system thinking is a first step, because at least you have a chain, and you're thinking about the interlinkages between the pieces, and it may make the hospital less centric, as Lawrence mentioned yesterday, less at the center of this whole operation, but it may involve newer groups or different groups or patient groups that traditionally have not been reached out to or involved in the process. Or new players may emerge that are not there, like the device manufacturers and so on. So that's kind of the world we're living in. And I want to shift to user innovation. So in this picture, who invented the bike that these people are riding? Which company invented this bike?
Schwann?
Anybody knows? Schwann, it would be one company, but no, it's a person, a user, somebody living in the mountain, wanted to ride his bike and decided that if he put fatter tires on the bike and maybe the handlebar could be straight instead of the usual bent type in a racing bike, he could actually do something that it would be fun to ride like that. Other people saw it and so on. It became a trend. Companies stepped in, and now you can buy one from your local company.
I have a question concerning the term of the firm and the user, because often these people, for instance, bicycle constructors, they are cycling, but at the same time they are also in the cycling business. So, for instance, they have a cycling shop or something like this. So, is this only a user, or is it somebody who is being in the cycling business, even though if he only has a cycling job, and he starts to reconstruct his own thing, and then he starts to, so is this only a user, or what is the firm?
Great question, but most likely it's a tinkerer, a bicyclist who's also a tinkerer, who knows a lot about bikes, maybe works at a bike shop, I don't think, but it's not the bike company.
Okay.
The bike company had this R&D process as to what the consumer wants, and they never thought, all these bikes, they never thought that they would want this. But it took a guy, a person, or a woman, but I think in this case it's a guy, who wanted something different, right? How about this stroller, the running stroller, or whatever you call it, racing stroller, running stroller? Who invented that? Again, somebody who, liked to run, had a baby, and these little strollers with small wheels did not cut it, and then kind of in their garage figured out a way to, they had an old bicycle, put the wheels on, and the running stroller was born. We're in Montreal, so that's Carey Price, but what shirt is he wearing?
Under Armour.
Under Armour. So it's an Under Armour shirt.
Person.
Yeah. So the person who invented, who founded Under Armour was actually a student in my old institution, the University of Maryland, and I heard it from him. He was on the football team. They sweated a lot. They had cotton jerseys, and that's very icky and uncomfortable if you're a football player in Maryland weather, right? Lots of heat, and humidity. So he went home, and I don't know if he got his mother, but somehow he used this synthetic material to create a shirt. His teammate saw him at the practice where he wasn't as sweaty as they were. They said, "Can I get one?" And soon he made some for the team, and then realized that could be a product, and it's invented this product. And most of us now, when we work out, at least many of us wear some of this. Right? It's a huge company nowadays. So, and something as mundane as the web was invented by a user. Sir Tim Berners-Lee, he's now Sir, he got knighted, invented the web basically because when he worked at CERN to support these physics, the high energy physics teams, there were lots of them and hundreds of papers, and people needed to share information, and photocopying wasn't cutting it, and they had to distribute the new papers, and so he invented the web as a way to distribute papers and solve his problem, which was supporting the timely distribution of physics results, and via that invented the web, right? So users are a big source of innovation, and definitely with the initial idea. And this is a pretty busy slide, but many other products. Some of my favorites are, the dishwasher, skateboards, chocolate milk, Graham cracker crust, lots of good stuff. The sports bra was invented by a woman who found that the bras that were available were not comfortable, and kind of, one of the key, so the table at the bottom just shows that there have been studies that show that basically roughly 5% of in any country, basically 5% of users tinker with products and engage in a process of reinvention and customization that is not what the design was for, right? So it's a very widespread phenomena. It's just understudied and not well understood. So why do they innovate? Many reasons. They want a product that's not available in the market. Basically, companies design products for the average user, average person, average consumer. They do not, there's a distribution of needs, and they take either the mode or the 80%, and they try to meet their needs. So car seats is an example. In cars, they meet the needs of people who are like between 5 foot and 6'3". Mm-hmm. But if you are shorter or taller, tough luck, right? You may, and some of these people have to customize these things. And the car companies say it's too expensive for us to develop a solution for you. You go find a specialist, kind of a different firm that will then customize it for you. And that's how the world is.
Among entrepreneurs, I look at Uber. Uber's the founding myth and story to some degree is that they were in Paris looking for something and came up with Uber. So the entrepreneurs in the Silicon Valley I talk to, it's often they're looking for solving a need that they personally have. And that's part of the passion and the ability. And I've heard that from entrepreneurs here in Montreal as well.
Yeah.
So, I think too of car companies that Ford took a large consumer study about what people want in their car, and this is like in the late 50s and early 60s. They wanted longer fins, they wanted more chrome and all this kind of stuff because that's what the consumer focus groups came up with. But that year the Volkswagen comes out and everybody sees this wonderful small car and it's efficient and all the rest.
Yeah.
And Ford has lost a lot of money making these huge cars that nobody wanted anymore.
We talked yesterday about laparoscopic or minimally invasive surgery. So the instruments that were being made by companies at the time had no idea as to how to do the operation, but the surgeons who were doing it said, well, an instrument that is straight like this rather than curved is difficult to use because you need something curved to go around something like that, right? And I spoke to some of the companies here, and they said, we don't make that. When I went to Maryland to visit Carl Zucker at the time, who was one of the innovators in North America, I said, this is the instrument I'm looking for. He says, yes. He said, we call this a Maryland. When I came back and I spoke to Storch, I said, you got to make an instrument like this, which they did. And that instrument became known as a Maryland. Everyone said, can I have a Maryland? That's what you got. So your state is really on the map when it comes to laparoscopic surgery.
Great example. Okay, so one important point is that users don't innovate just in their basement. I think in many ways people look for people like them. They like to share their innovation. They build community. They help others who have the same problem. So there's this innate drive for many of them to help others, right? And to learn from others, right? So you are part of that community of people who are trying to innovate with laparoscopic surgery, and you went to that. I mean, I don't know if you saw him as a community, but you were part of that same community. Community does not have to be people who are friends. Community can be community of interest, of practice, right? Those kind of ideas. Okay, I'm racing a bit because I want to get to the interesting stuff, which is this part. So that was just an introduction, and I want to talk about specific innovations. So, Innovation Zero. So this is an email I got from my own sister. My nephew got diagnosed with Hodgkin's lymphoma, and so this is an email she sent me. I don't know what to do, and so on. Now, lucky for my sister, as a patient, as a mother of a patient, my nephew was a teen. She is not the typical patient. She has a PhD in toxicology. She is a fellow at Procter & Gamble's, which is their highest scientific level. And she runs lots of studies and is an expert on the skin and has written at least 150 medical papers on these kind of topics. So she's probably the nightmare of the doctor who's trying to treat her son. But but we often simplify the relationship between doctor and patients as kind of a zero-sum game, or a loss to the doctor, or who have to deal with these patients who come in. I've read some crazy thing on the internet and so on. But in many complicated diseases, in many complex cases, an informed patient can be very helpful, and especially when there's no direct treatment, obvious, clear-cut guidelines. And the toxicity of the treatment for my nephew mattered, long-term impact. Can they go? What treatment will do for their ability to perform in school? Like all these factors come in, and the user is a big participant in that decision. It's not just left to the it should not be left to the doctor, because the doctor, the specialist, sees the patient for 30 minutes, and then that's it. And the patient and their family have to live with the disease and manage the disease, and including diabetes and all these other diseases, and they have to rely on source of information. So besides the information floating on the internet that may or may not be good, there are alternatives that actually are useful to innovations in basically in providing care and ensuring continuity of care, and I want to talk about that. So this is one community, and I'll point you just to that number there. I don't know if you can see it. 614,000 members are on this community. This is I took the snapshot this morning, and they have a running counter telling you how many people are on the platform. And here are the most recent members, and they have a variety of issues, and basically, if you have a rare disease or a condition that is not a simple condition, you tend to naturally gravitate to find a community of people like you and see what they are doing. And that is a very helpful, unique development over the last basically 10 years, which wasn't there before. Here's another community which is developed by an academic, a colleague of mine in Portugal, and it's called Patient Innovation. And basically, you may have, so you need to live with your disease, and how do you get help? And the medical professional, the pharmacies, or the specialized equipment stores may not have what you need, or it's not, or you may come up with a solution. So it's a community where people share how they have done things to work around their problem. And it turns out that users are actually, necessity is the mother of innovation, as they say, and so who better than a user to develop these things? So this website, or this one is not a commercial one, it's run by an academic for the purpose of helping people, and so their money making is not an issue, but they select every year the top 10 innovations that have helped the patients, and they distribute widely, and often companies come in and take those ideas and learn from them. So on the patients on the left side of the picture of the slide is patients like me entry, which again I'll point you to the number of how many trials are actively recruiting. 47,000 trials are recruiting patients. And if there's 600,000 patients in there, a lot of trials can be run. And again, this is a long way from the traditional way we recruit patients. I've talked to a lot of people at the MNI and at McGill, and for rare diseases, I mean, if you can find 5 patients, you're like doing great. But they're all there. They're all in this community worldwide. So you can have them do things and see what the impact is. It's a novel way to do science and medicine, right? they can very quickly come to results. Half of us, let's say we all have some disease, half of us take lithium, half of us don't, and let's compare, we're tracing our condition every day anyway, let's see if there's any impact. And you can very quickly figure out whether something's working or not, rather than wait 5 years for the studies to come through and the funding and kind of, it's a novel way to do things. On the right side is just a discussion paragraph, and I've highlighted the key parts about the patients, looking at patient innovation, and they did a survey of all these people on the innovation website, and then basically found out that 36% of rare disease patients, developed some improvement, some measure of improvement in the care that they were being provided, based on kind of inventing, reinventing, changing, and so on. And then basically, when you have a panel of professional caregivers, they looked at these innovations and they found them very useful and kind of because there was a concern about the safety of whatever people were trying out. And so a lot of it was fairly useful. So all this to say that the online community of patient phenomena is here to stay. I want to differentiate that from, I read on the internet that if I took bleach, my hair will regrow, or things, misinformation. But these communities try to kind of share information together.
So for the clinical trial thing, how do REBs feel about it, collecting patient data that way for clinical trials?
It's a touchy topic. I think some of these things are patient-driven. Patients, in one of the examples at the Patients Like Me, the patients themselves, there were no scientists involved.
Okay.
The patients decided that we hear that, can't remember which disease, it was taking lithium literally made a difference.
So the patients are running the trial themselves?
For example, yes.
Mm-hmm.
Now, there are a lot of scientists who now are very interested in running trials there because it's a lot easier and simpler, but these original trials were patient-driven.
Interesting.
And that makes a big difference. James?
So just the related question is, you're trying to kind of create a hard line between, those crazy people come up with conspiracy theories on the internet and try to do something dangerous or harmful, and like a measured community that's kind of driven by reason, and or a physician who kind of carefully taps into so but surely that's not a hard line. Surely that's a gradient, and I don't even know what that distribution looks like. I don't even know if there's a dip there, if it's just continuous. Maybe there's even. So what does it look like? Where are things that look legitimate, maybe on the surface, but obviously someone needs to instigate an intervention, and that could come from one patient in the community. It could come from a physician. It could come from some analogy that's posed outside and interpreted or misinterpreted. I mean, what does that boundary look like? And how should we think about that?
Yeah. So Patients Like Me is not a disinterested observer. They're making money through that platform. They are selling your data to pharma companies who are very interested in this, right? Now, as we saw in the previous presentation, the patient feels they're getting something out of it, so they don't mind sharing their data. And if sharing my data makes it a step closer to a cure, who am I to argue, right? So somehow the business model works for these parties, but the gray areas are the areas you're mentioning. And
is there an increased risk tolerance, for example, among these communities? I can imagine certainly at certain stages that there would be. I don't think that necessarily leads to crockery, but it certainly changes. They're basically placing their values in a way that shapes their choices, which probably fights against kind of classical Hippocratic commitments and things like this.
I think I agree, and doctors are usually very conservative when things are not clear, and they would go for a safe treatment. While if I am desperate and I'm feeling, I'm ill, and If somebody says on this community, or 2 or 3 people agree with them, taking bleach is a solution, and I may try it, right? So there is a potential for higher risk. That is not well studied or understood. I agree. Lance?
The extension of this, though, which sort of corrects the potential bias, if you will, in this sort of system, is Apple's health research kit, which enables anybody, but let's say any academic health center who wants to run a clinical trial to enroll patients basically without any cost involved. And the perfect example was published a couple of weeks ago from, I think it was Stanford, where they wanted to run a clinical trial. They calculated based on traditional parameters that they would need to enroll X number of hundreds or thousands of patients, that it would probably take them 5 years to enroll. It would probably require 50 centers, with each center contributing small number of patients. That's the old way of doing things. With the Apple Research Kit and the technology behind that, within a matter of weeks, they enrolled 50,000 patients in this trial, which was unheard of. And so it's all being run out of, I think it's Stanford. So there's traditional control in there. But the enrollment was just phenomenal, and it takes advantage of the community-ness of chronic disease, because people are looking for solutions, and Apple made it very easy.
So that's kind of the positive side of this. It changes how we can do studies, where we find patients, and so on. So at the very least, there's that. Most people, they did a survey on patients like me. 63% of them found that they have received actionable, useful information that helped them manage their disease from being part of the community. So there's something there also. I feel supported. I'm sharing today that what happened to me. There's also the socio-emotional support that is actually built in that community. So I'm not hearing from a social worker. I'm not hearing from some nurse, that doesn't know me. I'm hearing from someone who has my disease, right? And that makes a big difference. Okay, now moving on to, so this is innovation one. So this other stuff I added just because based on the discussions we have had yesterday, I was like, we need to talk about these things in a broader perspective. But I want to cover very quickly, and I'm not sure I will get to the end of this. 4 different innovations. So we lost our surgeon.
I'm a surgeon.
Yes, okay. So the Da Vinci robot prostatectomy. And now it's not a happy topic for men in this room, but it's that's what the Da Vinci robot is very good at. So robotic surgery is used for these kind of things. And meet Dr. Sanjay Razdan. Now I don't know if you know him or not. Dr. Sanjay Razdan works at the Baptist Hospital of Miami, and he's practicing in the Kendall Regional Medical Center. Would you consider the Baptist Hospital of Miami as a central hospital? No, right? And Dr. Razdan, he lives in Doral, Florida, which I don't even know where that is. It's probably a burb of Miami. But Dr. Razdan has developed some, first of all, by being at the periphery, and that peripheral hospital has bought a Da Vinci robot, he has performed 5,500 Da Vinci surgeries, which is on the high end, I would say. And he has developed a new technique where basically and again, this is where I'm not a clinician, but I saw the video about it. By adding a human amniotic membrane, when they cut close to the nerves, they reduce the amount of scarring and the amount of damage, and tissue repair goes faster, and the outcomes are quite good for people who undergo a prostatectomy. And he has received a prize, first prize at the World Congress for Neurology and Robotic Surgery in Taiwan. So, the question I have, so Dr. Razdan, let's talk about it as an innovation. He has published, he tries to publish since 2013, and so geographically and institutionally he's at the margin, right? So what are the factors that are going to affect the diffusion of this procedure? Assuming it works, I'm not certain how well it works, but assuming it works, like how long would it take for this procedure to become the norm, assuming it's as good as it appears to be? Any guesses?
A year?
A year?
15 years?
Yeah. So the typical medical innovation takes 15 years to diffuse. And I think the challenge in medicine is to how do you shorten that time period? And so we're going to look at several innovations to see if there is something to be learned from that. So
Are you going to look at why it may take 15 years? I mean, there's an inherent conservatism in medicine, which has something to do with the notion of protecting patients against harm. And there are very good examples of, I wouldn't call them innovations today, but at the time they were called innovations, that came onto the market very quickly in the 60s and 70s, which killed a lot of people. So in the late 50s, early 60s, gastric freezing stomachs as a way to stop bleeding from ulcer disease was a treatment. And the number of patients that died from that is incredible, but it had widespread acceptance for a certain period of time. The other one that comes to mind is the angel chick balloon, more of a donut than a balloon, that was used in the 80s as a way of obstructing the upper part of the stomach, the lower part of the esophagus, as a weight control measure. That also killed a number of patients. Never really well studied, but rapidly adopted. And it was not in 15 years, but it could have been in a matter of months. Obviously no longer on the market. So
Where did this begin?
where did this begin?
Did they begin at the periphery, or did they?
Well, it begins with an individual. Whether the individual is at the periphery or not is debatable. But most of these things begin with somebody having a crazy notion and testing it. And that's the other problem. You know, somebody who comes up with a crazy idea is self-invested in that idea and doesn't really see anything wrong with it. And it's usually other people that demonstrate what's wrong with it once it gets into wider use. But there are a lot of examples in medicine like this, particularly over the last 20, 30 years.
So, yes, that's the argument that safety is the reason we go slow. But assuming Razdan did 500 cases of this amniotic membrane, which I know nothing about, but seems, and the results seem good. His colleagues in that Congress have assessed it, and I'm sure, and he did a study, real study. What would be the other factors?
Yeah, I was just wondering, I think it's on the one hand patient care, but it's also some sort of an institutional resistance. Because as you are investing in large instruments, you would not invest in a new one because it has to be amortized and so on and so forth. So I think these are factors. And then I was wondering, I mean, it depends on the innovation. Do you have a very small, very practical innovation that might spread very soon? If you have large instruments and so on and so on, it takes as long as to test them and so on and so on. And the third one, I have to say this, I would expect networks are very important. I mean, who is the person who is inventing this? Is this some sort of a guy from Doral in Florida, or is this a big shot in Harvard who has holding already a couple of patents? And it's just, I mean, it's some sort of a credibility in the sense of how it
Okay, so let's test this idea. You have a Da Vinci in your hospital. You do a lot of prostate surgeries. You're a leading person in that field. What would they say if you went to him and said, you know what, there's this very nice innovation, why aren't you using it? What is the likely answer?
He would probably say that our rate of sexual dysfunction and incontinence is so low that it wouldn't make any difference.
We're
Because
doing well.
it's not zero.
Yeah.
I presume he's not saying it becomes zero.
Yeah.
He's saying it's reduced, right? I would imagine.
Yeah. So, but again, so that's a likely answer from the center. That's what happens at the center, and then and often these new innovations, these disruptive innovations, we only know they're disruptive afterward, right? They begin, their performance is not as good at the beginning. They improve over time, and they may exceed the traditional method, but at this point of time, we do not know. So we go conservative and we avoid taking the risk. We have done it well here. What's wrong with the way we do it? I've trained with so and so. I train people. We know all about it, right? And this guy's peripheral in wherever in Florida, Quack maybe, right? These are the answers you get, right? So I'll call these things FUD: fear, uncertainty, and doubt, right? Which is the typical answer when people at the center hear about an innovation from the outside. Okay. A second one, something you guys may or may not know about. So Parkinson's disease diagnosis. Very difficult to do, right? No cure. And then a lot of money is being spent on Parkinson's disease. And there's the largest foundation is the actor Michael J. Fox's foundation has spent already $750 million on the disease. So lots of interest, millions of people suffering from it, and meet this woman, Joy Milnes. Joy Milnes says she can smell Parkinson's, and basically she smelled it on her husband when he, before he was 6 years before he was diagnosed. And she told him he smelled different, and then 6 years later he developed Parkinson's, didn't think again about it. And then they went to a support group meeting, and she discovered that all of them smelled like her husband, right, at the Parkinson's people. So if you look at it as a timeline, so she discovers her husband smells differently. He gets a diagnosis 7 years later, and then at the support meeting, she smells the others. Her husband dies, I think, in 2005. In 2012, she's attending. She's still interested. She's a nurse by profession. She's interested in Parkinson's. In the middle of a lecture at her local hospital, she stands up and says, why are we not using the smell of Parkinson's to diagnose it early? And there was total silence. And but one doctor decided to take her on and said, we're going to run a test on you. I'm going to give you 6 T-shirts worn by Parkinson's patients and 6 that are worn by non-Parkinson's people. Can you smell the difference? And in this test, she correctly identified 11 of the 12. And then the point of disagreement was on one person who she said he had Parkinson's, and the person did not have Parkinson's. And then 6 months later, that person did develop a diagnosis of Parkinson's. So she was running at 100% accuracy. So this is in Manchester, in Scotland, and maybe you know about this story. It's a local story, maybe? No?
In England.
Okay, yes. So it's they do a spectral analysis trying to identify this. 10 molecules are promising. They're working on a basically creating a test where basically you put a swab on the forefront of somebody, and you can run it through a spectrometer, and then you have an early diagnosis. A lot better than previously.
Wouldn't that mean that's another like surveillance medicine technology? Everyone is going to start having to have these regular tests in order to diagnose it early.
That's one way to. It could go that way.
I mean,
but
I'm not saying it's bad,
yeah. But definitely, it's probably a better diagnosis than what we currently have, which is very much looking at, when do you develop tremors and things like that, right? So it's a more accurate test, probably. So the question is, again, where is Joy Milnes in terms of institutional and geographic core periphery or center periphery? And how long will it take for this innovation to be recognized?
In a similar way, what happened to the dog test for testing cancer? You don't hear anything about that now. I don't know if that just sort of went by the wayside or not, or are they actually using that as a diagnostic tool?
Yeah, because dogs would be even better candidates for identifying diseases because of they're so much more they're better at smell, right?
Yeah.
So what do we do with this? This woman was outside the scope of the system.
There are device companies now developing nanotechnology-based sensing devices on this concept, and I've seen that already being worked on and developed. So I think people will take this actually quite seriously, because if you have a technology available and you can show that the sensitivity and specificity of that device is very good, it might be adopted more quickly than we think.
Probably helps she's a nurse. It adds a bit of credibility, I think, that the average person wouldn't have.
Puts her closer to the center in a way.
Yeah.
I have a question about, is the nurse considered as an individual with a specific skills? And could the nurse train other people?
Well, it's like you're in the realm of the perfume testers and so on. There's a very small percentage of humans who have a very good sense of smell, and then you need to identify those people. And possibly dogs would be better candidates, actually, or testing equipment, right? But the fact,
because if we consider this, I struggle with a precise vocabulary. If the medical community consider this nurse as an individual with a skill, the line of discourse can be very different.
I do believe in this case, the fact she was a nurse is an accidental factor. What mattered is the nose, right?
This is what I
yes.
exactly.
Yeah.
This is why I ask.
Yeah.
You mentioned that one doctor at the beginning decided to her own. What is the general reaction of the medical community?
I do think once this story came out, but look at the timeline. I mean, it's quite a timeline. But the medical community will not be against. I mean, they are positive. I don't think there are institutional reasons why they wouldn't want this test, right? Doctors would prefer a simple test than the usual battery of tests they have to do to diagnose a disease. And if it can be diagnosed earlier, maybe pre-treatments, or we don't have a direct treatment, but there are peripheral treatments that may be helpful, and that would be the positive side of things. So for us, it's how many others like her are missed, really is the question. Because after the story came out in 2015, about a dozen other people came out, said they could smell Parkinson's in England, just in England. So there are many things, so that is kind of the issue, is like why did we not get this information before, or why did we not think of it? We have read for a long time that the dogs can smell certain things, and now you hear from other diseases that people can smell other diseases, and yet it was not an explored avenue. And I'm gonna think in terms of boundaries, because this is outside the scope of traditional medicine. That's not how we do traditional medicine. We don't rely on people's noses.
It doesn't come from the laboratory or from a clinical context, but it's interesting that it's being transformed right away into a test.
Yeah.
So it's taken out of that realm right away and made into a test for a lot of good reasons, but it's interesting that it then gets credit.
Yeah.
I want to make a point of the history and the nose. On the contrary, the nose was a very important part of very traditional Hippocratic and Galenic medicine when they tested the urine. It was very important. And the smell of the urine was precisely matched with disease. I think that the nose was important.
Tibetan medicine, especially with urine testing, with Tibetan doctors.
I agree. I didn't mention outside the Western, but you are absolutely correct. Even the color.
Yeah.
So I want to talk about another innovation, and
Sorry.
it's your area.
Yeah.
I did not know that was your area, but H. pylori infection is an amazing story. You may remember these medicines. This was a $3 billion industry that kind of disappeared kind of very quickly, and it's introducing Barry Marshall, which some of you know. He he has many prizes. This is his Wikipedia entry here, but he got the Nobel Prize in Medicine for this. So he grew up in Western Australia, a fairly isolated area, and then started working in Perth, and then he's well known for drinking this bacteria, giving himself ulcers, and then solving the medical mystery. And this is the paper he published with Robin Warren, who shared the Nobel Prize with him, which basically it's in the Lancet, 1984, and it basically says there are bacteria living in the stomach of people who have ulcers. There's a specific kind of bacteria, and in terms of timeline, it's interesting to know how the accepted knowledge was, and I guess we do have people here who can talk about it firsthand. But the accepted knowledge then was that the overproduction of acid causes ulcers, and your high stress lifestyle is the most likely cause of that, right? But there's a bedrock assumption, a very basic truth, which is that no bacteria can live in the stomach because of the high acidity. That's kind of the medical assumption behind it all. So gastroenterologists were doing a booming business. They chopping the bottom of stomachs and reconnecting the pipes. They managed the disease. The pharma companies, $3 billion in acid blockers, and then Barry Marshall and Robin Warren discovered the presence of H. pylori bacteria. And they discovered it, they had an inkling that it would be there, But they did biopsies on 100 patients who had this disease, and it was a very prevalent disease. And the interesting twist is that they would send the sample to pathology, and it would come back negative, 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 until it was Easter holiday, and the lab waited 6 days before they threw out the sample. But they tested it at that point and discovered H. pylori. And it turns out it took more than 2 days, which was a typical time, I guess, to grow these things. And so accidents matter in science, right? So they start sending papers. They get rejected by the Australian medical community. And then they're prohibited from experimenting on people. So out of desperation, Barry Marshall injects himself with a brew containing H. pylori and promptly develops gastritis. A week later, he's able to cure it by taking a normal course of antibiotics. And the finding is, it's proof. The proof is in the pudding, as they say. And then they start publishing in journals in 84, 85. But it takes at least 10 years. For the gastroenterologist did not accept that very simple paradigm-shifting discovery. And FUD was involved, and you can imagine the industry did not look favorably upon losing a $3 billion market. So it's only after 98 or 2000 that it became accepted, and a lot of it is driven by word of mouth and patients asking, or kind of experimentation. So let's talk about Barry Marshall. Why do you think it took so long, and what are these factors? And you probably have a frontline view of this, Lawrence.
This is not an unusual story. I think a lot of times people working in what we would consider to be the center are very constrained by peer pressure, tradition, conservatism, even though academic centers tout themselves as being innovative and on the cutting edge. Really, the flip side of that is they're there to protect how they got there, which doesn't allow necessarily for a lot of new innovation to happen. And so when you read about something like this, or an individual who as an individual would be considered marginal, I don't think it's unusual, because those are usually the people that are unconstrained by traditional mechanisms of constraint in their thinking. They're not subject to it. It would never occur to them that they have a crazy thought, because having a crazy thought is relative, right? It's relative to how everybody else is thinking. So if you're sort of in isolation, it's a lot easier to have a crazy thought than to be in a group of conservative people where your crazy thought wouldn't be acceptable or tolerated.
It's also typical history about a thought collective who thinks about that bacteria did exist in the stomach, so this is the thought collective, so to say, out of...
It's a paradigm.
Yeah, exactly. And then it takes some time as an external to get, so to say, the shift, or to manage the shift somehow.
I would add that there's maybe an exception to what I said, and that's the personality of an individual. And the example I would cite is the individual who developed liver transplantation at the University of Pittsburgh in the 1980s, whose name, Tom Starzl. Yeah. So Tom Starzl, who I knew, was the type of individual who didn't care what people thought about him. And he was a real bull in a china shop. And Tom Starzl, at any other institution, probably would have been shut down, because he killed his first 10 patients. I mean, if somebody tried to do an operation here and killed their first 10 patients, I can tell you, they wouldn't do the 11th patient. But he got away with it because of who he was. And he really built the foundation for what we accept today as modern liver transplantation. So I think who you are, and maybe not only where you are, is important.
The flip side of this, how many dumb ideas have been killed rightly by the system? So we always rightly focus on, it's like entrepreneurs, 9 out of 10 fail, but I don't bring them to class. I bring out the one successful one. It was if I did, the students ask me, what are you doing? I brought one guy beyond the rack who failed, but he was on to his next thing. So he's willing to talk about it. So, you look at, if there's 100, that kill many, many patients, maybe the system's not being bad, it's actually being useful as a counter thought.
Yeah, I mean, we've discussed a lot the center periphery question, but maybe it could also be useful to problematize the innovation diffusion dichotomy. And so it's easy to sort of think, okay, this is innovation, this is then something else that happens after the innovation is different. It's making it routine, it's boring, all it's doing is applying the innovation on a scale. But those processes of making routine and creating infrastructure and scaling up can also involve innovations that are maybe less exciting and less visible. And it may be also hard in a lot of these cases to, if you actually look at the longer term process between when the first operation is done and when people are doing thousands of operations every day, there may be a kind of continuum where it's hard to say when the innovation stops and the routine use begins, and in fact there's a kind of continual interplay between innovation and routinization. And so that might, I thought, based on this conversation, but also in the last 2 days, that might also be worth bearing in mind.
Good point.
Just to give a more positive spin on what the institution, the conservative, non-innovative institutions are doing, they're actually probably doing a lot of large innovation on a large scale that we just don't see as innovation because it's less exciting in some ways.
So I want to cover one last innovation, and then I want to open it up. So if
It's dark. Can I turn a light? It just seems dark. I'm kind of peering. Can I just try one light, Samer?
Sure.
Is it just hard to see you and the other people?
Yeah. Thank you. So one last innovation. One last innovation is the Canadian electronic medical record called OSCAR. Meet Dr. David Chan. He's a fellow here, the taller fellow. He's standing there with Martin Dawes, who was a chair of family medicine at McGill. Oh. And you may know him. Yeah. And this is the Queen Elizabeth Urgent Care Clinic, and I took the picture. So I was there, and I carried the printer. I still, my back still hurts from it. but this is a shoestring operation, clearly, if they rely on me to carry the printer from the store to the place. And it's basically, David Chan came in and helped set up the EMR. It took him half a day. He left his clinic in Ontario and came to help set up the first one. And they're holding the first prescription that got printed out of that clinic. And so an electronic medical record looks like something like this. You guys are probably, especially in Europe, you're very familiar with it. Canada had been a laggard. It's now fairly well diffused. A lot of commercial providers. But the OSCAR electronic medical record is doing quite well. These are the location of its Canadian clinics that have used it. There are 3.5 million Canadian records on it. Again, it's a free open source piece of software, and it has even diffused to Jamaica and to Kenya, Uganda, and several other places in the world. So back to our community idea, it's a community behind it, the user community. Doctors are not computer scientists. David Chan had an undergraduate in computer science, which helped him develop this thing, but the user group is where the action is at. and basically it's a user-to-user kind of training. We help each other, and we use this innovation, right? So there are lots of sites, and the history or the timeline of this is interesting. It started out at McGill. Dr. David Chen was at McGill in family medicine, and he was adamant that they needed to computerize their offices, and he developed something called MUFFIN, the McGill University Family Folder Information Network. McGill did not see fit to support Dr. David Chen.
Maybe if you had a better acronym.
And he moved to McMaster University in Ontario, where the university is supportive, and he was able to launch OSCAR, the renamed product, in 2002. It's under the general public license. It's free for anyone to download. You don't even have to be a doctor to download it and to make modifications, and there's a thriving community being done surrounding it. First installation in Quebec is at the Queen E, as I said, and it became bilingual. Now there are multiple languages. It's one of the few where actually multiple users in the same office can use different languages at the same time, right? So it's unique. It's certified by Health Infoway and Ontario and Quebec, and there is it has exceeded a 20% market share in Ontario, right? So it's a lovely story. In terms of diffusion of the innovation, it costs like typically it costs $1,000 per seat to buy an OSCAR installation, while for the commercial vendors it's between $20,000 to $25,000 per seat. Seat meaning a user. It could be. It's not just doctors. Could be nurses and administrators. And the recurrent costs are relatively cheaper. It links well to these are acronyms that mean something in Quebec. The DSQ is a cloud-based solution that the province has developed for all medical information to reside there. OASIS is a McGill hospital system, the pharmacies, the labs, the imaging, communication between them, and their AMQ billing database, which is important for the functioning of the office. So if you're running a clinic, would you use this innovation? And why or why not?
I can tell you that when he was at Queen Elizabeth Urgent Care Center, we were working there with Dr. Mark Roper, and they were thought as crazy because they wanted to implement that, and it was contrary to the government setup that was totally controlled by the ministry. And Dr. Roper thought that the government setup was so heavy and complex and not that user-friendly. And so he was very much into it, but they were thought as weirdos. I remember that. And now he's still using it. And he's very, very happy with it.
And they train the users. One of the key aspects is for many of these technologies, you cannot just read about it. You cannot just it's published somewhere or you get a brochure. It's not enough. You need to see it in action and try it yourself. So Dr. Mark Roper, who runs the Queen E Center, has basically every couple weeks he has a session that's open to outsiders, and they come in and they try the system. So he made it, and of course he doesn't get remuneration for this. He makes it his mission to help other doctors computerize their offices. Now that's a unique set of skills, and he's a unique innovator that way, right? Dr. Martin Dawes now has moved to British Columbia, where he's doing the same over there.
Another part of the risk is it's a group, so there's no one making money, no one going to invest in developing it over future. So there's a risk it may fall to the wayside. But when you look at the groups you have, that rarely happens. But it might be as a risk, a perceived risk.
Yeah.
Okay, we're soon going to have to stop. So maybe a few more questions, and then we'll break for lunch.
So I'm going to move to my last slide. So
okay, good.
Because I would suggest that the general discussion about your topic could be also moved to the general discussion of the whole conference, because it's very much goes in the same direction. And we do have a serious time issue because we have a couple of things to do during the lunch break.
So I can stop now? Or we can keep going?
No.
Actually, I'm more, so in summary, we have talked about the web as being important, and that's not changing. That's a new reality, and doctors have to get used to it. It's kind of, right? I do believe, from looking at a number of cases, including everything discussed over the last 2 days, that most innovations develop at the periphery, because that's where people who have unmet needs reside, and they become the innovators. So central institutions, life is good in central institutions. We were, they shape the dominant worldview, and they're part of it, so they have less incentive to innovate. Doesn't mean they don't innovate, but it's more traditional innovation. Radical innovation comes from the outside often. It's important to recognize the cognitive, social, institutional, economic forces that can hold back your innovation from diffusing. So the best example are the pharma companies who lost this $3 billion market for antacids. They didn't go easy. I mean, they didn't just say, "Oh, okay, bye, see you." They fought it. They commissioned doctors to speak against it. They started talking about the danger of antibiotic use, and those kind of arguments were made. Very similar to the debate on climate change. The similar in any issue where someone has something at stake and the innovation takes away from you, you're going to fight it. And it's important for us as researchers to recognize these things, not as smooth processes or logic will win or medical goals will win, right? So the training component is crucial. I think several people have mentioned that the hands-on training at somebody's lab, visiting, these kind of things is too risky for many of these innovations if you don't do it yourself under the guidance of somebody. And that's one lesson I think is emerging in other settings too. And I'm actually disappointed that I couldn't say anything different than that, but the 15 years seems to be here to stay. That I don't see anything that will change that. I haven't heard anything the last 2 days either. I would have liked to see that the web will change things, but I don't see it.
Okay, so thank you very much.